Hi, my name is Nidhi Sharath, and today I'll be presenting my research on the automated brain tumor segmentation using deep learning and UNet architectures. My research primarily focuses on improving the automation of brain tumor segmentation using different deep learning methods. Brain tumor segmentation is essentially the process of identifying and outlining different tumor subregions within different MRI scans. In my study, I compared several neural network architectures through comparative analysis to determine which one of them performed the best. I focused on four different model architectures: the convoluted neural network, or the CNN, the cascaded UNet, the 2D dense UNet, and the regular UNet. The main goal of my research was to evaluate how effectively these different deep learning models can segment brain tumors. I optimized my models by improving their shape and their volume accuracy to try and address the question and determine the effect of different architectural choices on segmentation performance. Furthermore, I addressed another important objective of both computational efficiency and precise tumor boundary detection. Brain tumors tend to be highly complex with varying shape, size, and texture. So the early and accurate tumor detection plays a crucial role in increasing the quality of life of different patients across the world. Automated segmentation systems also reduce the workload for medical professionals as the manual segmentation process tends to be tedious and prolonged over long periods of time. Furthermore, brain tumor segmentation helps with the early prognosis, early diagnosis, and early detection of brain tumors over a period of time. It can also help optimize the treatment pathways and improve the clinical outcomes for different patients. For my research, I specifically focused on the BRATS 2018 or the Brain Tumor Segmentation 2018 dataset. I utilized the high-grade glioma subset as the BRATS 2018 dataset had too much data to consider as a whole. Underneath the HGG subset, there were 209 patients, with 167 for training and 42 for validation. The split between patients ensures that the data did not appear in multiple sets, keeping my models and the training as accurate as possible and preventing the possibility of a data leakage. I specifically focused on four MRI modalities: the FLAIR, the T1, the T1CE, and the T2. The image on the right depicts the cropped T2, the cropped FLAIR, and the cropped T1CE obtained from the BRATS 2018 dataset. As mentioned before, I specifically focused on four deep learning segmentation models: the UNet, the convoluted neural network, the 2D dense UNet, and the cascaded UNet. For these models, there were certain hyperparameters that were fine-tuned to help optimize the performance, and it was trained under a set number of epochs to ensure a stable learning curve. Furthermore, the models were trained using the Atom Optimizer with the fixed learning rate. The grid of graphs on the side represents the dice coefficient over the number of epochs for each of the models that I tested. For the methods, the training was performed over multiple epochs and repeated multiple times. However, early stopping was implemented to prevent overfitting. Overfitting essentially prevents the over-learning of data to ensure that there are no drops in the accuracy of each of the models. Furthermore, I utilized dropout and batch normalization to improve the generalization. And the dice coefficient was the performance parameter that was used to evaluate the performance of each of the models. The dice coefficient refers to the volume overlap between the predicted mask and the ground truth mask. The evaluation metrics are essentially parameters for the evaluation of each of the models. I specifically focused on the precision, the sensitivity, and the class-wise dice coefficient for different parts and different regions in the brain, such as the necrotic, the edema, and glioma, and etc. As depicted by the images on the left, the graph and the table of and the images shows the predicted mask versus the ground truth mask for the UNet model and the cascaded unit model. The predicted mask is the image that is generated from each of the models, which is compared against the ground truth mask to check how accurate the image given out by the model is. The tables underneath are the training and validation performance metrics and the test performance and classification metrics for all the models. The values indicated in bold depicts the best performance against each of the parameters for each of the models that I tested. The graphs depict the validation accuracy against the set number of epochs that I ran for, with smoother graphs depicting stronger generalization. As seen over the results, it shows clear differences in learning stability between the architectures. The more advanced the architectures were, the smoother the validation curves and the stronger their generalization. The dense unit and the cascaded unit especially reduced noisy predictions and improved the boundary precision. Overall, the results highlight that the impact of model architecture on the segmentation performance plays a big role in brain tumor segmentation. Over the study I conducted, I came to the conclusion that the 2D dense unit outperformed all the other models. It especially reduced the noisy predictions and improved boundary precision and achieved the strongest overall performance along all the evaluated models. The performance is partly due to its dense connectivity and information flow between each of its layers, improving its feature extraction. Some of the limitations that I faced with my study was the elevated performance metrics and the elevated accuracy I received from my models. This is partly due to the pre-processed nature of the BRATS 2018 dataset that I used. The data has been cleaned in a lab already, so it prevents and it doesn't have many imperfections within it as a normal unpreprocessed image might have. In the future, I want to use more lab brought data so I can test the robustness of my findings and the accuracy across actual real world data. For the improvements and future work, I want to be able to integrate attention mechanisms or transformer-based modules across my models. And I want to make the move from the 2D dense unit to the 3D dense unit to enhance the spatial context and intersite consistency. I want to improve the segmentation of challenging tumor subregions through richer contextual learning, and hopefully have real-life data to confirm the robustness and accuracy of my findings. Thank you for listening to my presentation.